Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. NIK NIKAM from Houston, Texas, and this is Cardiology Seminars. We have more than 160 videos on our YouTube channel covering various cardiac topics. Welcome you to watch all of them for free. The feature presentation today is heart murmurs, basics. We're going to be covering the basic aspects of heart murmurs for nurses, medical students, residents, and internists. In the next presentation, we're going to talk about heart murmurs advanced feature for cardiologists and cardiology fellows. Focus on some basic things that we can detect at bedside, whether we are seeing patients in the clinic, in the emergency room, or on the floor, or in our office practice. Heart murmurs are generally produced by turbulence created by movement of blood across the heart valves and heart chambers. Whenever there is a disturbance in the flow of blood, we are going to hear a murmur. In a normal situation, when the blood flows smoothly without any resistance, without any obstruction, without any interference, we don't hear a murmur. That's why when you listen to a young, healthy adult, you hear loop, doop, loop, doop, loop, doop, loop, doop. You don't hear any murmurs. However, if you take people with high flow, like during pregnancy, in patients with anemia, in patients with thyrotoxicosis, when there is an increased blood flow, or in patients with chronic renal failure with AV shunts and high output states, you're going to hear a systolic murmur like lub, 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 doop, like that. It is a short systolic murmur. Whereas most of the pathological murmurs are related to structural changes in the heart valves, be it mitral valve, tricuspid valve, pulmonic valve, or the aortic valve. Mitral stenosis causes diastolic murmurs. Mitral regurgitation causes pansystolic murmurs. I'm going to explain to you why we hear these murmurs and how long do these murmurs last and what are their qualities. Similarly, with the aortic valve, we can hear an aortic stenosis or an aortic regurgitation murmur. With tricuspid valve, we can hear a tricuspid stenosis murmur, which is similar to the mitral stenosis murmur, or we can hear a tricuspid regurgitation, which is commonly heard in patients with combined left and right heart failure, or patients with pulmonary hypertension who have severe tricuspid regurgitation. Then pulmonic stenosis and pulmonic regurgitation are fairly uncommon, but if we have pulmonary hypertension, we can hear a pulmonic regurg murmur, which is actually used to calculate pressures with the Doppler studies. So we talked about the high flow situations, and we talked about the valvular structures that can cause heart murmurs. One condition where we're going to hear a continuous murmur is in a patient with a patent ductus arteriosus that connects the congenital patent ductus to the pulmonary artery from the aorta. And if the patent ductus arteriosus is open, then you're going to hear a continuous murmur like and the heart sounds may be muffled. Okay, that is the basis of these murmurs and their origins. Let us focus a little more in depth and try to understand the timing and the quality of each one of these heart murmurs. Let's talk about the timing. We hear the mitral regurgitation murmur during the continuous systolic phase of the cardiac cycle. Why is it called holosystolic and why is it called continuous? Because there is a pressure difference between the left ventricle and the left atrium during the entire systole, as opposed to aortic murmurs which stop at the closure of the aortic valve. That's why we get a holosystolic murmurs. Whereas patients with mitral stenosis, we're going to hear the mitral click and a diastolic rumble in the diastolic phase of the cardiac cycle. So these timings will help us to understand why we hear certain murmurs and their quality. For example, the aortic murmurs are harsh. They are crescendo, decrescendo, like whereas mitral regurgitation, it's like a band, it's going continuous, whereas the ejection systolic murmurs related to high flow are like whereas aortic stenosis, it is and the severe the aortic stenosis, you're going to get delayed closure of the aortic valve. Okay, those are some of the differences. Let's look into the actual tracings of the phonograms of these situations and see if we can learn some more in detail. We have the lub doop, then we have the lub doop doop, that's the S3, or we have the lub doop doop, lub doop doop, lub doop doop, lub doop. Okay, now here we have the aortic stenosis murmur, which is crescendo. It starts as the pressure builds up and then it reaches a peak at the peak systolic pressure and it comes down before the aortic valve closes. So we have a lub doop, lub doop, okay? Whereas mitral regurgitation, because of the pressure difference throughout the entire systole, we hear the lub, lub, lub. So that's the mitral holosystolic pansystolic murmur. Aortic regurgitation happens during the early phase of the aortic diastolic phase. So we have the, of course, we are going to have systolic murmur if we have associated aortic stenosis. But anyway, the duration of this depends upon the end diastolic pressure. If the end diastolic pressure is high and there is equalization of the aortic and the end diastolic pressure, then we have a short diastolic, early decrescendo diastolic murmur. It comes right after the closure of the aortic valve. So we got a, let's forget about the systolic for now. Lub doop, lub doop. It's a very soft murmur, so you have to use the diaphragm and have the patient kneel forwards and have the patient exhale so the valve gets closer to the chest wall, and that's when you hear the aortic regurgitation murmur. The systolic murmur is radiating all over the chest. It will go to the apex, it can radiate to the carotids, whereas this one is very localized. That's why you have to listen to it in the second intercostal space. Mitral stenosis, on the other hand, we have lub doop, dup. So we have the first sound, the second sound, sometimes you hear the opening snap due to this calcified valves trying to open. Then we have lub doop, rumble, and then the second sound. And finally, we have the patent ductus arteriosus, which I talked about, which produces machinery murmur. It's similar to the murmur if you put a stethoscope on an AV shunt in a patient with renal dialysis. You hear that. Okay, that's and here's a different depiction of the same murmurs. Aortic stenosis, we have a crescendo, decrescendo murmur, and it stops at the aortic second sound. It has to. Whereas with pulmonic stenosis, it can continue beyond the closure of the aortic valve because there is increased pressure in the right side of the heart. So we get a P2 coming in later than a 2. And of course, the mitral valve prolapse, it is not pansystolic because in the initial phases, the mitral valve closes normally. Then we have a click, mitral click, followed by a pansystolic murmur after that because of the incompetency of the valve. And HOCM is very similar to aortic stenosis. It has a crescendo, decrescendo murmur. with the atrioseptal defect. Again, we have to see anything that prolongs the right ventricular ejection phase increases the murmur beyond the aortic second sound. So we have a crescendo de like that. Patent ductus arteriosus, we talked about machinery murmur, and of course we have the also systolic murmur seen in mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. If you have a patient with a myocardial infarction and you hear a classic pan-systolic murmur, the first thing you want to do is get an echocardiogram to see if there is a ventricular rupture as a complication of an acute myocardial infarction. So, ladies and gentlemen, this is again summarizing, and here we have the third heart sound and the fourth heart sound. And the areas are very important. If you're looking for mitral murmurs, like the holosystolic murmur, you listen to them at the apex, which radiates to the left axilla. If you are talking about tricuspid regurgitation in a patient with pulmonary hypertension, you're going to hear that best in the right lower sternal border at the tricuspid region. If you're hearing for pulmonic systolic murmurs, splitting of the second heart sound or reverse splitting, you listen to them in the pulmonic area, which is the second left intercostal space. Similarly, aortic murmurs are best heard in the right second intercostal space by having the person lean forward so the valve comes closer to the diaphragm, and these murmurs, systolic murmurs, can radiate to the carotids, which can mimic carotid stenosis. So this is a brief summary of the heart murmurs basics. Before I conclude, I would like to get to you a free copy of my Cardiology Rounds manual, which has 127 pages of chock full of information. If you're starting round as a nurse, as a student, or as a fellow, it will be a great help to you, and you can get that for free by sending us an email to drniknikam@gmail.com. And this has been a presentation of Cardiology Seminars brought to you by NIK Media. I am Dr. NIK NIKAM from Houston, Texas, and please do subscribe to our YouTube channel, and we will see you next time.